Doing good.
Good. So tonight's session is going to be really informal, and really the objective is primarily to continue this thread of leadership, clinical nursing leadership, healthcare leadership that we've been, that kind of wanders throughout PC 730, 731, and 732. Last term, I think you guys had a session that, or had some content dealing with onboarding and onboarding new members of the, and so tonight's session is really going to be about ongoing quality assessment, performance evaluation kind of issues. And the next term, the follow-up to this will be some content about preventing burnout, which is really good information too. But so for tonight, we're going to keep it very informal. And what I really was wanting to do to start with is just have everybody give me like a 2-minute introduction. Tell me who you are, remind us again of your clinical setting, your project that you're doing. And so we'll say 2 or 3 minutes. I'm not really timing. I'd like for you to just tell me one good thing, one good change that's come about this week. Hopefully you're all having changes that you're witnessing. So I'd love to hear about what's going well for you. And so just for those of you who I have not officially met, I'm Eileen Thrower, and I'm part of the course faculty, of course. So who wants to start? Katina, do you want to start? Because you're on you're the first one on my list. Are you talking, Katina? Because we can't hear you.
Hey, I'm sorry. I don't think I was supposed to be on this call. I just answered my phone.
Oh, were you not? Your name is on the on my list for the live learning session tonight.
I'm sorry. It's that was probably early in the semester, so I'll let you guys go with your conference.
Okay, great. Thanks.
Sorry.
Thanks. Okay, Ilana. Is it Ilana?
It's Ilana.
Okay. All right. Well, then you get started for us then.
Sure. Hi, I'm Ilana. I'm a certified nurse midwife in Massachusetts. I am not currently employed as a midwife. I'm working as a registered nurse on labor and delivery at a tertiary care hospital in Boston. So my project is about breastfeeding. So I am trying to improve exclusive breastfeeding rates in our hospital on the postpartum floor. So I've been working a lot with the nurses on postpartum. And I had a really rough PDSA2 cycle with the nurse manager not really being on my side. And she's my manager for work, so it made it even more difficult. But this PDSA has definitely felt like we're going in the right direction. I haven't had as many conflicts, especially because I'm not focusing on labor and delivery anymore. And it's really great. The nurses have all expressed, they like what I'm doing, and the patients really like what I'm doing. So hopefully it will take off and keep going even when I'm not doing it.
Good, thanks. I'm glad to hear a positive report. Sorry you had a rough couple of weeks there.
Yeah.
All right, Erin.
Hi, I'm Erin. I work at a CABC accredited birth center that does birth center, home birth, and hospital birth. My project is on perinatal depression, and I am increasing screening and follow-up for women during pregnancy. Prior to the implementation of this project, we were only screening clients at their 4-week postpartum visit, and now we're screening at the first prenatal visit and about 28 weeks whenever we do their glucose tolerance test. So my project has almost kind of plateaued because my partners have almost like checked out. Like they're doing it, but they don't want to change anything. So the good thing is that they really like the changes that we have made so far. They really like the tools that we're giving our clients, and they really feel like this has been a good change, and we're going to continue it. So.
Okay, that's good. There's at least a positive thing there, huh?
So it's kind of busy. The one of the midwives is planning to go to ACNM next week, and then another one is planning a vacation following that. And there are only 3 of us, so I'm going to be on every other day starting Sunday for 2 weeks.
Ouch. Okay, yeah, that's not fun.
No.
Okay. So next is Haley.
Hi, I'm Haley. I work in an outpatient primary care setting, seeing families. I work on a military base, so I have a special kind of population. I'm a nurse practitioner, by the way.
I kind of put that together.
But piece that together. The biggest change I think that I've seen this PDSA cycle is that my patients are finally engaging in what I want them to engage in and returning back and seeing some progression. So I'm kind of excited that this has happened, and I'm hoping it can continue and kind of stretch into some other areas of the PDSA cycle. So
excellent. So, and
that's what I'm doing.
did I miss it? What's the topic of your project?
I'm doing dyslipidemia.
Okay.
And screening and just high-risk populations.
Okay. So tell me, what state are you? Where are you located?
Oh, I'm in Washington State.
You're in Washington. And what about you, Erin? What state are you in?
I'm in Missouri, St. Louis.
Missouri. Okay. Okay. I don't know why it seems like it's just interesting to put a place to people. So, okay, Kate.
There we go. So my name is Kate. I am a certified nurse midwife. I'm in Oshkosh, Wisconsin, though I practice in Milwaukee, Wisconsin. I am the women's health at Milwaukee County Jail and doing perinatal, and we, prior to the project, were doing no perinatal depression screening for the pregnant women in jail. And so we decided to go all in and are doing at a first visit somewhere around the 3rd trimester, hopefully around the 28 weeks, within a week the time they deliver, and then at a 6-week postpartum. We are also including women that get arrested within 12 weeks if they haven't had a follow-up postpartum and or still breastfeeding up into the 12 weeks as well. One of the biggest, I guess we'll call it a success this week, or this PDSA cycle, is we incorporated at the end of the last cycle into this one in the booking area when people get arrested, to have them do a new set of questions to find out not just if they're pregnant, but also if they've delivered or had a miscarriage or abortion within the last 6 weeks. And so getting the booking nurses on board has been a special kind of challenge. However, this week in particular, the first week of this PDSA cycle was not awesome, but this week in particular, 2 nurses that are all in came back in and sort of, I think, started threatening people and put up signs and did a thing. So they've actually been asking, and we got a really, I mean, I don't know if it's necessarily the best news ever, but I got almost double the amount of people that I did on my first 2 PDSA cycles. That were getting hit and actually getting appointments set. So that's been, I guess, the win that I've had. Yay, more people are arrested, but they got identified. It's the win-lose part of that.
We're going to say it was more people identified.
There we go.
That?
There we go. It's warm. People are going outside, have enough energy to commit mayhem.
Oh. We're not going to say that was one of the outcomes of your intervention.
No. Just to get them there in the first place.
Yeah. Okay, Marina.
Hello, I'm Marina Roloff. I'm a family nurse practitioner in Yuma, Arizona. My project is on the comprehensive care of type 2 diabetes and ultimately improving that care with a personal diabetes care card toolkit that I'm using. So far, it's been pretty positive. I've had good feedback from patients. So far within the PDSA cycles have brought their card back with them, so that's good. I personally find it very helpful, kind of as like a little checklist to make sure you address the 15 things you have to for diabetic patients and get everything ordered. So I think overall it's been pretty good.
Okay, thank you.
All right. My name is Ryan Barrowman. I'm assuming it's me.
It's you. You're up.
So my name is Ryan Barrowman. I'm a nurse practitioner. I'm working in southern Utah, kind of like right in the wedge of Arizona and Nevada. We're about 5 minutes away from both. So if that gives you the little picture you want. I work at a pain management setting, and my project, what I'm dealing with is trying to get right care or best care into practice for people getting onto opioids. So that's the right care of onboarding. And then when patients have been seen and they start misusing their medications, I'm implementing a way to do right care for patients who are misusing, and then patients who are being discharged because they refuse to follow in line. I'm also getting right care for that. My big news for this week. So ultimately, the best news for me could be that we were going to find a way to keep these patients who we would normally discharge and have a way of helping them with their addiction at that point. And I didn't even think that would be possible. Luckily, one of our competitors just started an addiction wing, so to speak, in their department or in their business. And so my boss came up to me and asked if that was something that I could get going. So we're going to, instead of just dismissing them and say, oh, you're on your own. That was really what happened with patients. So we're hoping to help people to stem the opioid crisis a little bit, at least in my town.
Well,
That's
very
really cool.
Yeah, that's very exciting. That's awesome.
This is before they end up being my patients. Awesome.
Yeah, I actually worked in a jail setting for about 10 years, so I know what you're talking about.
I'm like that we're doing anything. That's so awesome. That's
that's good. And it sounds like you're all having some good changes going on. And so, the session tonight, the rapid fire session kind of approach to having a meeting is an interesting kind of an idea for group meetings that you're going to be probably facilitating as leaders within your systems. So if you've got a group of people and you're trying to make change or sustain change, as we're talking about, this is a kind of an approach where you can have a facilitator, you can have a timekeeper, and you have a scribe. You basically give people a limited period of time to go around and give their input into how they feel like the change is going, how they feel like you can maintain the change. The scribe kind of keeps notes on all of that, sends all the notes out. So it's a way, particularly for issues. Who was it, Aaron? Aaron, were you saying that Aaron, you said that your staff were like, okay, we made the change, fine, let's go on. Is that?
Yeah, I think it's just because everything is like our biller quit and we've had a recent turnover a little bit. So I think it's a lot of like, they have other stress. So they're like, let's not change anything. And they're kind of not really, they like what we're doing. They're not invested in like, let's do more.
Yeah. Okay.
It's interesting to hear with your post, because I've been following, because I've been in like every group with you, Erin, about your perinatal depression stuff. Because I find that my group, and granted it's a pile of family nurse practitioners and a couple of docs, so I don't get like even the buy-in of having more midwives in my life, but that like, they're like, look, we did a thing. We're cool with this thing. There'll be no more things. no, really, this is our thing. That's it. No, we're not talking about more things. And it's interesting to see that, you know, that in the other part of the world, they're like, yay, we're happy with our stuff. You can stop changing now.
Exactly. Yes.
Well,
this is enough for right now.
This is one of many challenges that we have as leaders in quality assurance within our settings. You know, so it doesn't sound like you had a huge problem with buy-in and getting people on board with your idea, but then they're like, boom, done. We don't really want to keep that going. So this was part of leadership, and this rapid fire kind of approach to a meeting can be a way to use it. What we're also going to talk about tonight, though, is the results. Well, kind of some of these questions that were in the survey that you guys filled out, because another part of the role as a DNP prepared advanced practice registered nurse is very likely you're going to be in leadership roles. So you may be involved in onboarding other APRNs into your organization. You may be involved in ongoing performance evaluations. You may be involved in just overall quality improvement or quality assurance for your organization. However, those wherever your involvement is, it takes a little bit of work to make sure you're doing all these things the way you want to be doing them. But let's talk for a little bit just about the idea of ongoing performance evaluation. So if we're working on this idea within our organization and we're trying to determine the way we're going to do this the best, okay, that's kind of where we're really wanting to use our best practice even in our approach to doing our leadership kind of functions and administrative kind of functions. So let's talk for a minute about the way you guys are seeing performance evaluation done. And so the first question is, do you have a job description at your site? You want to all chime in really quickly and say, if you do, tell me anything about it that you like about it, that you don't like about it.
We do, and ours is very vague. Just basically, it says you're going to work as a nurse practitioner, dealing with patients with pain, blah. Stay within your practice. Other than that, there's no real meat to it, I guess.
So yeah, so it sounds like it's there, but it's somewhat useless, huh?
That's kind of mine as well. That, like, and particularly I think because I'm the only midwife or anyone who does what I do there. So there's sort of this kind of basic nurse practitioner one that says you'll see people until you don't, and anything else we think is necessary, thank you, is basically what it says. So it's there, like, so I check the box, it's there, but yeah, not much else.
Okay,
I don't know a whole lot about the, oh, sorry.
No, go ahead.
I don't know a whole lot about the job descriptions for advanced practice, nurses. I don't know, exactly what it says. I know they have one. For my job description as a nurse, it's pretty, it's not specific to L&D. Like, they give the same job description to all of the nurses flat across the board. You're going to do this and this and this and this and this. But, whether you're in the ER or in the office even, I think we all have the same job description.
So did it just basically sort of list the general responsibilities and duty of a nurse, formulating care plans, administering? Okay, so
yes, exactly.
Kind of a generic list of what a nurse would do.
Exactly.
That could be, okay. What
anything else deemed necessary.
Yeah.
Basically, yeah.
Yeah.
I have the polar opposite.
Okay.
I work for the federal government, so mine is completely laid out. And if I go past something, then I get my hand slapped or fired. So, but it's very detailed to the point that, like, even my credentialing is like distinct for minimal things. It's kind of silly.
So yours is sort of cookbook, kind of a design where it says exactly you may do this and then this and then this.
Mm-hmm. Yeah.
Does it go so? Does it also function as like a policy manual? Or it's just really a list of your scope of, like a very detailed list of your scope of practice
It's just a very detailed list. It's 3 pages long.
of what
And
you are credentialed to do and not do.
No, that's not even my credentials. Those are just the like job
Oh.
description of what I'm allowed to do. And then I have a separate one for my credentials. It's completely different.
Mm. So does
So
it
even
tell?
though it's state, I'm full practice in Washington State, but I can travel as a federal employee. If I work at another federal area, then I can still be full practice. So that's kind of the only benefit.
Mm-hmm, mm-hmm. Okay. Marina, what did you find? Or go ahead, Erin.
Okay. Mine has kind of a general description, a little bit more than what Ryan or Catherine are talking about, but it doesn't describe like what my role is and like duties that I can expect to do, things like that. So it describes probably somewhere in the middle.
Okay.
Can you guys hear me?
Mm-hmm. Yeah, we can.
Okay, my computer keeps freezing, sorry. I do not have a job description at my place of work. I work at a very small privately owned practice. It's pretty much owned by a nurse practitioner. She works 4 days a week, and when I started, there's only one other actually new grad from FNU that works 1 day a week. So it's pretty much just us. I think it's just a matter of never having all of those formalities executed,
Mm-hmm,
but
mm-hmm.
scope of practice.
So then I suppose then the next question is, if you have a job description, is it linked in any way to your annual employee performance review? So clearly for Marina, I hope it's not. Otherwise, I guess, unless you're not getting a performance review.
In mine, the only thing that's linked to the performance review is pay. They monitor how much we're making during the year, and then based off of that, they'll tell us, all right, you're more valuable to us this year, let's go ahead and give you a raise. But otherwise, that's all that we really talk about.
Oh, so your entire performance evaluation is linked to your productivity or your billing, your receipts.
Yep.
Interesting. So no patient satisfaction surveys, none of that.
They don't. And so, but to sorry, I'm slipping over my words, but to give them a little credit, patient satisfaction is very highly sought after. It's just not written anywhere. We all just want to do really good care and that's the attitude in the place. It's not that it's lacking at all. So maybe they just haven't thought that they need to address it.
Because it's sort of the culture of the setting. Okay. Interesting.
I mean, we're reviewed based on.
Oh,
Go
sorry.
ahead. Go ahead, Alana.
Right. We're reviewed, based on, how well we perform, which I guess is description because they're all nursing processes,
Mm-hmm.
but it's not a, like bullet point of, this is in your job description and I hope you're doing this, 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 and this. It's just because it's so general, you can say it is based off of it because you're being reviewed that you're performing well as a nurse.
So do they bring in patient satisfaction surveys or any other criteria of that nature?
Not for performance reviews.
Okay.
They definitely tell us about it, but it's not directly linked, to our reviews.
Okay.
Yeah, patient satisfaction for us is reviewed about once a year, usually at one of our meetings. But my performance review is basically based off of their perception of how I'm improving, how well I'm getting my own tasks done. But we share clients, so there's no like productivity or anything like that, since we all We all just take shifts. So
Interestingly, we don't do patient satisfaction at jail.
I guess not.
Actually, the interesting part was they actually started to, and we have gotten them, but they are in no way tied to our performance review. It's more of a discussion point about how people like us or don't like us. But as far as, you know, the annual review stuff, as far as I can tell, because we don't bill, right? So I don't have a productivity moment. We don't do peer reviews because you're not supposed to be looking all up in everybody else's charts because of, well, jail. And so for the most part, it's really the perception of the medical director and your interactions with her about how she feels about your care. Have you had anybody, you know, go amok? Have anybody died? Sued you? Things like that, which, yay, not for me. So, but generally, like my last review was basically like, good job. I like it. You kept your numbers up. There were no due tasks, and your the logs that I keep on, you know, pregnant women that come in and stuff were up to date. Awesome. That was the extent to what I got. And then she gave me chocolate.
Oh, well, chocolate is good.
Which, instead of a race, that was basically just chocolate.
Oh, chocolate is not good then. All right, Haley, what did you find?
So because I'm a new nurse practitioner, I had a 1-month performance review, and then I had a 3-month performance review, and then I'll get a 6-month, and then a year, and then after that it's just annual. But it's kind of a little bit involved with other things we were talking about. Patient satisfaction, they do like a quarterly patient satisfaction in general, but they'll tell you if you have any complaints against you. So then they kind of will try to correct if there's anything like that. But they do that, and then we have like peer reviews within our performance reflection. So it's kind of, you get a well-rounded idea of how your peers think about you, and because we do share patients and they read our notes, and you know, it's very fluid. So it's kind of cool that we do get a lot of feedback. So it's nice.
Yeah, that's nice and kind of unusual. You're not going to see that very often. I don't
The
think.
government has that.
Yeah. And so with this elaborate job description you have, is there a performance evaluation sheet that they're using, that they're using to evaluate you with? And if so, does it correlate at all to the job description, or do you know?
It just is like, it has like a kind of a checklist, I guess. Like you stay within your job description, you're providing quality care, or, you know, I don't remember the exact questions that are on it, but it goes through more or less that you're not going outside of your job description and you're not underperforming. So it kind of just makes sure you're.
Interesting. Okay. Very interesting. Maria, we haven't heard from you on this one, have we?
Mine is similar to Ryan's, actually. It's more about performance and how many patients you're seeing and how many hours you're clocking. So basically productivity. It's not linked to patient satisfaction. I've been there for almost 6 months now. And I think I've had 2 performance reviews. Kind of just sit down, and I mean, as a new grad, you know, she realized there's going to be a curve as far as amount of time charting and things like that. So we kind of just establish a goal and make sure we're working towards it. And that's pretty much how our reviews have gone so far.
Well, you know, I am going to say, I think this is a nice, visual display here among the 6 of you. The variety of what you've seen in performance evaluations, and I'm telling you, it's going to sort of be all over the place, but I think you've kind of given us a fairly good representation of what you see. From, you know, on one hand, it would just kind of like, hey, good job, keep up the good work, yeah, here's your 3%, you're doing great, all the way to it's 100% linked to your productivity. So Ryan, what what would happen if you were less productive this year than you were last year?
This is my first year working, so
Would you?
probably nothing. No, but I know for my
I mean, over the course of the years, would some of your salary be at risk if your productivity went down?
I don't think, like, I don't get that impression. I didn't ask specifically. I signed a contract, so my second year I automatically get a 3% raise. It's not even tied, but at that point, when we go to renew the contract, that's when they'll review what my productivity level is as far as bringing in patients or anyway, I think my perception is that if I perform well, then I get a lot bigger raise than if I'm not. I would still get a raise, but probably it's more negotiable upwards if I'm showing how valuable I am.
Okay.
Surely that's going to plateau.
Yeah, I mean, I'm sure it will. The other nurse practitioners, I gleaned more from them because that's kind of a sensitive topic. It's a smaller group, so that's transitioning into a big group. So there's still that small business feel, but definitely a big business feel coming on. And I think that at least in my setting, there's a pretty big curve I can go up before I plateau. But
I mean, sorry, not your pay, but your productivity. Like, you can only see so many clients in a day.
Yeah. So, and that's true. So really, let's say at my third year, I'm only a 3-year nurse practitioner. I've got this many patients. I'm bringing in this much. So I'm wanting to get this much more this year. And then 2 years later, I can say, you know what, I'm still maintaining this. I'm making you guys this much money. I've been with you this many years. And so now I want this much more and maybe a day off on Fridays, something along those lines.
Gotcha.
It's just very interesting. And this is something to be on the lookout for when you are considering new employment opportunities, and when you're if you're involved in leadership and you're working with performance evaluations. Some places will, for you, it's determining the size of your raise. There are places where it determines the size of your bonus. And so your salary may be here, and with the bonus, it's where it's supposed to be. But then if your productivity isn't what they expect, then your salary may not really, part of your salary may be at risk because they are looking at it as a bonus. So there's always interesting things to. I will also tell you that I find it very interesting that none of you have your performance evaluation linked right now to patient satisfaction, because that's certainly something that I think I see a lot of places.
I did when I was in private practice, in a group practice that was owned by the hospital. It was, I don't want to say that was the main thing, but we got performance evaluations and patient satisfactions in like 3 different ways. Like, they did the Press Ganey stuff, they would do the immediate stuff, then they would do like the reviews that they would send home after people had babies, and your RVUs. And they had the bonus structure as well. Like, you get this sort of base, but if you see this many people in your RVUs are cool and you're here with your gynae stuff, then it goes up. Then you get the percentage of how many people had babies. And so it was hugely tied to your RVUs and your patient satisfaction and the evil of the Press Ganey.
Yes, which
evil
can
of
be
the Press
just, yeah.
I do not miss the Press Ganey at all. And I always, like, now, like, when I look at jobs and think about jobs, like, that's one of my interview questions. I'm like, so let's talk about patient satisfaction really quick. Because while I think that it's an important topic, I think that, when you tie everything to whether or not I was an awesome waitress, I think, and when I think about like pain management or, other things like that, I'm like, well, how high did I get you? Did I make you leave because you didn't comply? So now you gave me a nasty Press Ganey? or something like that. So I think there has to be some sort of lines in there.
Yeah, I've had exactly the same experience. I think most of us probably have with the patient satisfaction score. So these are things to keep in mind and to, you know, not only as employees when you're going to work, but also if you become, you know, if you decide to own your own practice or you decide that you become higher up in administration, you may be involved in these kind of strategies. I think that there is a case to be made for linking the performance evaluation to your job description, and this is what you're expected to do. And so are you doing it? But it's food for thought. But that brings me to the next topic of conversation, which is benchmarking. Um, benchmarking is an interesting sort of twist on this. Really and truly, like Ryan is describing, I think for a lot of employers, the main thing is the productivity, not the benchmarking. But I think benchmarking is a really important, we need to be involved in. All right. So tell me about your experiences with benchmarking. Anybody doing any of it?
Mine will be
I don't
quick.
think we are.
We don't.
So no from Ryan, no from
No,
Elena.
I don't think so.
Absolutely none.
Wow. Okay, great. Hey, Aaron, tell us about benchmarking.
Good job.
We enter our data into the perinatal data registry. Unfortunately, though, we don't get those results often enough. Like, it's really only once a year that we actually get the stats from that. Perinatal data registry is basically you enter everything about their pregnancy into this system. Like, when was their first visit? When was the last menstrual period? What number baby is this? Are they planning an out-of-hospital birth? Did they actually get to do that, or did they change to a hospital birth? What time were they in active labor? How long was their labor? Basically, like, it tracks outcomes, not patient satisfaction, just actual objective data. So.
And is that that's the only place that you're entering all of your information?
Yes.
Okay. Because it is, I will have to say, it can be a little overwhelming because there's a lot of different places to do it. I know in terms of the midwives among us tonight, the ACNM does a benchmarking, has a big benchmarking project. And I think that's a really important one to be involved in. But regardless of where, on the F&P side, I do think benchmarking is important because it at least allows us to compare what we're doing and our outcomes oftentimes to other practices similar to us. So, for Aaron at the birth center, you may be do you know what your C-section rate is off the top of your head at the birth center?
No, I don't. Not off the top of my head. I want to say we were told the result. I want to say it was like 13%.
Okay. So,
I don't remember.
We'll say let's say 10 to 15%. In any case, well below the national average, less than half of the national average is what it sounds like. So if we compare you to somebody, Elena, or Alana, do you know what the C-section rate is at the hospital where you work?
It's in the 30s.
Okay. So, and so this is the kind of thing that benchmarking allows us to do. Not necessarily comparing the C-section rate. Is your hospital's tertiary care? What did you say about the hospital?
Yeah, it's a tertiary care hospital with a NICU. So we have some very high-risk patients. Like the vast majority of patients are being induced. It's kind of a surprise when someone actually comes in labor. We have a lot of, C-sections, planned C-sections, you name it. We get all the transfers from the other hospitals in our little network because we're the one with the NICU. So somebody, goes into preterm labor, we get them. And so we get all the train wrecks.
Right. And so it's not fair to either one of you to compare Alana's C-section rate to Aaron's. That is ridiculous. We would expect you to have very disparate outcomes in the terms of the number of C-sections you're doing. But I think it's very interesting when you compare one tertiary care hospital in an urban setting that delivers 5,000 babies a year to another tertiary care hospital in an urban setting that delivers 5,000 babies a year. And then we see huge variations in what people are doing. And that's really a way to track some of the variations that we're seeing. A hospital, because you're in Missouri, but if you looked at a hospital in Miami that was a similar size and had a similar acuity of patients, the C-section rate would probably be double yours. It would probably be closer to 50 or 60%. And so those kind of things are really important for us to know. I apologize for being a nurse midwife and being able to come up with an example related to midwifery much easier than I can an example related to the F&Ps. But I think that if you're looking at compliance with HEDIS measures or compliance with diabetes care or compliance with chronic kidney disease management, whatever, there's going to be variation in how people are how people's outcomes are looking based on their settings and their locale and all of those things. And benchmarking is the way that we can really judge how we are doing compared to people in settings very similar to us. So my main thing for that is you should be looking for opportunities to participate in benchmarking when you can. I think it's really important for our profession, but it's really important for our individual practices. So, Erin, one point you made about getting the results back once a year, I think that's going to be pretty typical. It's the kind of thing that takes a little while, and probably if you're turning in your results right now for 2016, it's going to be 3 or 6 months before you get those results. So there's always this lag. But on the bigger issue now is data registry and healthcare in our country. What do you guys know about participating in data registry? Anybody doing anything on that kind of lines? Which the perinatal registry is really probably more of that than, or it could be looked at as both. Anybody else doing any kind of?
The only thing we report is deaths on anybody.
So which are sentinel events, I think, right? In a jail.
Yeah, but we don't count any levels of morbidity at all. Or if they get released and die, we don't get to talk about that either. Only if they die in custody. And anything else as far as any of their stats, because of the way that all of that works, they don't really keep track of any of it. The Department of Justice does a little bit in the federal prisons, but on the state levels and at the jails, there is no reporting.
Well, and I think that, I mean, obviously, anybody else doing any kind of data registry?
Well, I mean, we don't participate in the other registries, but we have to report obviously everything to the state. So in Massachusetts, they put out, I don't know if they do this in other places, but they put out birth data specifically every year or two, but they're like 2 years behind. So the most recent that came out was 2015. And that shows by facility, by where they are, how many births, how many are low birth weight, if they had adequate prenatal care, early term, late term births, etc. I believe it also has the C-section rate somewhere, VBACs. It has, total cesareans, primary cesareans, repeats, VBACs by hospital. So you can actually compare the hospitals that have similar number of births and say, okay, well, this one has 26% and this one has 31%. I wonder where I want to go.
Yeah, so at the hospital level, they really are participating in some benchmarking and some data registry. But do you know if that information is coming from birth certificate data?
I have no idea where it's coming from. I wish I knew. I don't know.
I think a lot of the birth data does tend to come from birth certificate data, although as we
probably does. They ask for everything. Although they don't put cesarean on the birth certificate, though.
Is it not on there? I thought it was on there.
I don't think it's on ours. Log? Yes, we have a log. So they probably get it from the log.
My old hospital used to
Um,
do, they pulled it off of their billing sheet because there's a specific billing sheet where it would say how many weeks they were, if they were induced, how they delivered, things like that. And we would have to hand in this like paper that had all of that on it, which was kind of like what would be on the birth certificate with just a little bit more to it. I've always kind of seen this kind of gone away. It just occurred to me, by the way, we do report sexually transmitted diseases. Yay, I do something. I'm like, woo.
I was going to say that too. That's like one of the only things we report, and lead, positive lead tests in blood.
Oh, interesting.
Oh wait, and gunshots. We have to report gunshots too.
Okay, we report STDs too.
Yeah,
I'm sure we
most-
do as well. I'm sure we do as well. We have
Yeah.
to report certain STDs to the government.
Mhm, mhm. Is there any date? Is there any kind of registry related to pain management? Do you keep track of anything, Ryan?
That I'm aware of. Like when I asked him about that, he's all, no, we don't, I don't really, and I can't think, we don't do testing for STDs. If we were in addiction, we would, but there's nothing that we really report. We were brainstorming it, trying to think of stuff, and couldn't come up with.
Do you? Okay, forgive me for not knowing how pain clinics work, but do you primarily give your patients a prescription and they go take it to the pharmacy?
Oh, I was already unmuted. Yeah, we do. Mostly we try and do like steroid injections, epidural steroid injections, joint injections, non-opioid based treatments. Okay. Obviously, we do have our opioid population, but yeah, we do send those, just a hard copy with them.
Okay. Because I can tell you that the pharmacy can pull all of your opioid prescriptions. Oh, yeah. So that, you don't track it, but it gets tracked for you.
Don't track it. Right. We do pull Doppel to make sure that what our patients have been taking, but we don't report it.
Yeah, yeah.
I was wondering about that because Wisconsin just passed this thing that anytime that you write an opioid prescription, you have to enter it, so that everybody else can go see when you go prescribe for somebody if they're getting it from someplace else. So I just didn't know if is that, I guess it's pretty much more of a state thing than an everybody thing. Does Utah have that?
We have Utah, a state one like that.
Our pharmacies are the ones that put it in. I don't.
Yeah, in Arizona, we have a prescription monitoring program where we each have our own login and we can sign in and see what doctor has given what prescription for, whatever opioid. So if somebody comes in, they're a new patient asking for pain meds, I can sign into this and see, how many prescriptions they filled in the last, year or whatever. But it's certain states have it. Like usually it's just within Arizona. But that's not reported. That's just, I think, based off pharmacy information when they fill the prescription.
I'm just wondering why we don't have that nationally, because it's not like people don't cross state lines to go get their opioids, or because Wisconsin, Minnesota, we're so close, like Arizona, Colorado kind of thing, or Arizona, New Mexico. They're like, oh, you're on a registry over here? Hold on while I go over to New Mexico real quick.
A lot of states won't fill my scripts unless I'm in their state. And maybe my patients are lying to me. I don't think so, but they can't, if they're going on a trip back east and their refill date is 7 days away and I won't let them fill early, then they're kind of out of luck because they've tried it before, and say Minnesota won't fill a script from a nurse practitioner in Utah, but it would be nice if they did. Yeah, and they had a national registry.
And if we've had that, if you call it into a place that's, like anything other than opioids, the nurse practice won't cross the line. But if it's anything else, like you call it into, say, a Walgreens, right? And then they can have it moved from a different Walgreens. But the opioids, it's only the docs that they'll let go across the state lines.
Dumb.
That answers all the problems right there. Well, the thing of it is, I think it's something to really think about. If we're going to be looking towards ongoing quality assurance and ongoing quality improvement at every level, the macro, the meso, and the micro level, it's really got to be based on knowing what we're doing. And it's really kind of impossible to know what we're doing if we don't track it somehow. Another real challenge that I have found, and I don't know if any of you have discovered this, but it seems intuitive to me that if I'm putting all of my patients' records into an electronic record, then I should just be able to ask Epic to tell me what my C-section rate is or how many new OB patients I saw in a month. And I've really found that to be quite challenging because I think oftentimes if you're an advanced practice RN in a large system, you probably don't have access to running those kind of reports. Have you guys had any kind of experience with trying to get reports from your EHRs? Has anybody been successful with it?
In the jail system, there's 1,000 or so reports that you can do. It's one of the most convoluted EHRs though I've ever experienced. It's not the joy of Epic and the kind of reports that you get that. So we can get them, but then it'll print you out like 400 pages that you have to wander through and back to and go back into the charts because it doesn't collate it well for you. But you can get the data. It just is going to be man hours on it.
How about you, Haley? Are you able to get reports from your system?
This is where networking came in handy because I made friends with the population nurse. So she could just pull records that I don't have access to. So she's kind of been my BFF through this whole thing.
Oh, isn't that interesting?
Yes, making friends with the QI nurse.
Yeah.
She is what has made my little life okay.
Yeah. All right. Anybody, guys? Does anybody have other comments? Things they are thinking about in terms of, I mean, the other issue is what do you do with sort of conflict management within your organizations? That can be really tricky, particularly if you find yourself in an administrative kind of setting. If you're in charge, if you have some hiring and firing or oversight of other humans, it can be kind of tricky. Have you guys seen things that have worked well? Have you seen things that have worked poorly? You have comments you want to make about any of that?
We have the nursing staff is all part of the Massachusetts Nursing Association Union. So everything is laid out, just flat out there. You need to do this, and then you need to do this, and then you do this, and then you get fired. So it's supposed to go through that. So if there's any kind of conflict or something happens or what have you, okay, well, first you go to your nurse manager, and if the nurse manager doesn't do something, you go one step higher. So it's laid out very clear.
For us, when I'm in office, the amount that I oversight is very little. Like we have a receptionist and an MA, and so basically but I'm making more like medical decisions, things like that, managing like who needs to be seen first. Conflict management is extremely informal. There's no like what Ilana's talking about. You do this, you get 1 strike, 3 strikes you're out, and that's it. Or you get written up. There's none of that. It's very if there's a problem, you're chastised about it. It's very not so professional. There's a lot of growing that this business needs to make, and a lot more professionalism. And oftentimes, when you do something wrong, it's you find out by text in a not very nice way. So yeah, that's what we've got.
And I think that's one of the more challenging places to deal with conflict resolution. And when you're in a small setting like that, where you become, you're working very closely with somebody, it can make it very challenging.
Mm-hmm.
I would assume that the Army or the military has a they have a plan for that.
Yeah, they have like a go through your chain of command, but you have you get like a verbal warning, and then you can get a written warning, and then after so many, then you're kind of done. I think it's the 3 strikes you're out as well.
Ours is very informal. No chain of command. You just, very, very small office. There's like 5 of us. So also makes project implementation very difficult when you keep pushing and you have a lot of pushback and you have to work with these people every day. So challenging.
Ours is informal as well. We'll just find out a couple days later that someone had been let go because there's no formal process of, okay, here's your warning. Our office manager will just pull us in and say, hey, we need to talk. This is what we're seeing. But you don't know if that means, oh, okay, next time I'm fired, or I've got 20 more of these, or this is just how he reports to us. We don't know. It's just kind of how things go.
I'll add that even though we have this very formal way of reporting things, that doesn't mean there's no cattiness or little notes left on your desk that say, oh, by the way, you didn't follow policy. And, there's definitely that stuff that goes on as well. So it's always an interesting environment.
Well, I think it's definitely a setting. This conflict resolution topic is one that you're going to have to be faced with throughout your careers. And as DNP prepared APRNs, you are going to be more likely to end up in a role where you're the one trying to decide how to complete these performance evaluations. How do we decide? How do we figure out how we can spend the little tiny bit of energy we have to do some benchmarking or to do some data registry? How do we deal with conflict resolution? These are all issues that are at least good to be starting to talk about and think about, because you may find yourself in charge of one of these things. And I think the way to deal with that is the same way you've been dealing with the things that you've been doing in your UI projects. Do the research, find out what the tools are, find out what the best practices in leadership and in management, in conflict resolution. You're not going to spend 8 weeks doing it, or 3 months or 9 months doing it, but you can do kind of this miniaturized thing of what what you've been doing in these projects, and apply that to all these things as you go forward. So, all right, anybody have questions, comments, last remarks they want to make?
I think it's kind of nice to see when I filled out my benchmarking thing, I felt kind of like, well, we do nothing. Everybody else is cooler than we are. And I had that moment of, everybody else's grass is greener, I guess. It's kind of interesting to see which ones work and which ones don't, and that, benchmarking is not, because, my one other main experience was in this super regulated, on top of it, hospital. But to see how many, places kind of have the hodgepodge of whatever worked for them versus, what I would visualize as you should have all of these things. That's just kind of interesting to see.
Yeah, I think working at a CABC accredited birth center, I think there are a lot more things that maybe we're doing a little bit, but it's really not done the right way. Because I see I think the last survey we did was really eye-opening for me. Like, since you're CABC accredited, oh, are you doing this, this, and this? I'm like, oh, no, we don't do that. So it's really interesting. But to see the wide range of what everyone's doing is really interesting, and we're benchmarking.
Yay! So is there somebody, do you have a director or someone there that's keeping an eye on all the CABC requirements for maintaining your certification and making sure that those things are being met?
So Yes and no. There are now 3 owners. So there are the 2 original owners. One is a midwife and one is a nurse. The nurse is kind of the PDR is her baby, that benchmarking. She's the one that really makes sure that we're actually entering our data, that every patient is put into it. And then the midwife, she owns the majority of the practice. And she's not very good at delegating and sharing information and like this stuff. Like, I think if she did her DNP, I think it would really benefit her practice, but I don't think she has any intention to ever do that. And she's not really someone that responds well to constructive criticism, very defensive. I don't know. I lost track of what the question was, but
That's okay. Yeah, we're just mostly talking about is somebody trying to watch your certification and maintain all
That's
the
right.
if you're
Yes.
crossing your T's and dotting your I's.
Yeah, she's been doing a lot of policy review lately too, but she takes on a lot and she doesn't delegate really well and doesn't really like share the love much. So
Anybody else observed anything?
I guess I keep thinking about how our conflict resolution works. We have formal policies about, like, you know, if you screw this up, you get written up, that kind of thing. I've never actually seen it happen. What happens instead is every couple of months, people get punchy and start talking bad to each other. And the medical director makes us go out for dinner and have drinks together, where we bond, talk smack after a couple of drinks. And then everybody's happy for like 3 or 4 months. This is literally our ritual. And I've never actually seen
that sounds
because
awesome.
I've been there almost 3 years now, and there's a few people I would have really written up were I to have any level of that power, but I don't. That were never really taken that direction, and it was the like, hey, maybe some public shaming with some liquor involved. We'll work this out, and that's really what we do. And wow, there's not a formal process to that. But next Friday, it's time again. We have reservations and everybody is expected to show up. It is a mandatory, there will be drinks, please bring a drive.
So maybe this is a DNP project, intoxicated public shaming.
It works. It works. You know, and I think we have, huh?
Does your manager pay for the dinner?
She usually either pays for the dinner or she pays for the drinks. Usually one or the other. It depends, I think, of how much drinking was involved that day. But it is universally, I think, seen as, because it's such a, I don't want to say that everybody else's job isn't incredibly stressful, because I know it totally is, but there's so much drama and emotional shenanigans that goes on in the jail, that being able to make sure that you trust the person that you're sitting next to, and that you can walk into a room and get something from them, and that you know, can talk smack about them, because we use vocabulary in jail that isn't often approved of other places. And so being able to have that kind of a relationship with the coworkers has made a huge, this was instituted 2 summers ago, like sort of informally, and it's become our thing in how we deal with things. And there's 11 providers, so there's 11 NPs, and 2 docs and a dentist that comes.
So this is a totally informal meeting. Nobody comes with an agenda. It's not a staff meeting.
Oh,
it's get drunk and talk smack. That's it.
Basically. Yeah, occasionally we've had a couple people had babies, a few people have brought their children, and they don't have to have drinks, but they have to sit around and socialize with the rest of us while we do.
But it does sound like sort of a bond, a time where you really do kind of are able to bond and make some friendships and relationships that helps,
I think it's changed how, it's definitely changed how we react with each other, versus being people who just come in and do a thing and say hi and all of that. And respecting what other people do, because so many of us do so many different things there. So Yeah, public shaming.
Well, I would just challenge you as DMP prepared APRNs as you're going forth and becoming leaders to look at each of these areas can be very challenging. You know, you may be involved in reviewing your peers, reviewing other APRNs. You may be doing some of these conflict resolutions, but my challenge for you is to remember that there are scientific ways to approach all of these topics. Literature says, go and see what toolkits there are related to. We've already learned there's a lot of things about team engagement, right? Well, what about conflict resolution? So just kind of keep those kind of things in mind going forward. That's my thought for the evening. And that's about all I had. Anybody else have any other questions, comments, or snide remarks?
I liked all of the Jill snide remarks. Those were awesome. I want that setting.
I'm just saying, my new research project, drunken shaming. Drunken public shaming. Who knew that could be the project?
Maybe you could create a whole bundle, like a toolkit related to it. I'd be willing to be a participant in creating a toolkit.
I'll join that study.
We'll all.
We can write that up. We can tour with it and, you know, be able to demonstrate it as
but mostly we're going to be
method.
touring I think we're going to be touring in bars.
Obviously.
Yes.
Only. Yeah.
Cool.
All right, guys. Well, thank you so much for coming tonight and for participating and sharing your thoughts. I always find it really fascinating to, just as you guys are saying, to compare. Oh gosh, I feel horrible because we don't ever do any benchmarking. And then you see the 5 people sitting next to you are doing very little benchmarking too. It makes you feel a little bit better about what you might be doing and what might not be doing, but we all know what our goals are, and that is we need to be participating in benchmarking and data registry. So thanks for sharing your experiences.
Sure.
Thank you.
All right. Y'all have a good night.
Thanks, you too.
Thank you.
All righty. All right. Bye-bye.